In 2024, I had the privilege of joining the APT program. It was a truly outstanding opportunity to receive high-level training in pharmacometrics and to connect with leading international experts. One of the highlights of this journey was being mentored by specialists from the Eli Lilly PKPD department to work on an exciting project focusing on ADCs. This experience not only strengthened my skills, but also gave me the unique opportunity to publish my first paper in the CPT journal. Building on this experience, I became actively involved in other initiatives of Pharmacometrics Africa, including the launch of the Tunisia chapter, the very first French-speaking chapter dedicated to promoting pharmacometrics among Francophone Africans. I also had the privilege to serve as a faculty member for the first French edition of the online pharmacometrics course. This was an extremely enriching experience, both scientifically and personally, and it confirmed how essential is it to provide training in French to support our community. And now we're looking ahead to the next milestone. Very soon, we will launch the next session of the French pharmacometrics course. It will be another exciting opportunity for Francophone students and professionals to access world-class training, collaborate with experts, and join our growing African network. Rejoignez-nous très bientôt pour la prochaine session du cours en ligne de pharmacométrie en langue française et devenez acteur du développement de la pharmacométrie en Afrique. Merci.
Welcome back. Vaishni, you here. So welcome back everybody to the afternoon session of the first ever Pharmacometrics Africa conference. Vaishni, please take over and bring our online delegates in line with what the plan is for housekeeping.
Yes. Afternoon, everyone, and welcome back. Hopefully you're not too full and you got the blood pumping in the poster session, so there's going to be no snoozers in the audience. For the online guys, we're just going to go through some housekeeping rules and all those that have just joined us for the last session of the conference. So could we please ask all virtual delegates, place your questions in the Q&A button and use the chat function just socially. We would appreciate that. And then for our physical delegates or in-person delegates in the room, please wait for a microphone before asking questions. This actually helps us on the virtual side to hear you more clearly as well. And then just a reminder to keep the social media going. So please do use the following hashtags, and we are really looking forward to seeing your posts. Thank you. Over to you, Catriona and Ochuko.
Okay, welcome to the third session of this conference. My name is Orherhe. I'm a lecturer at Obafemi University in Nigeria. I'm also a PhD student there, and it's my utmost pleasure to be here, co-sharing with my boss here, who are sitting on this seat with such a woman. But I'm glad to be here. This afternoon, we're going to be having two speakers, and I think I will want Catriona to take it up from here to introduce one of the speakers.
Thank you. And I think one of the things that's absolutely delightful about this is that when you introduce a speaker, you're not just introducing a colleague, but you're introducing a friend and a mentor and somebody that has inspired many people in this room. So it gives me a great pleasure to welcome Karen Rowland-Yeo. Karen did speak at the Digital Health Africa conference, and if you were not there, it was a fantastic talk. It was almost 6 o'clock in the evening and the audience was just captivated. If you know Karen at all, I could give you her professional CV, but that would only tell a fraction of the story of the woman she is. She is inspirational. She has her heart set firmly in Africa. And she also blends the scientific with the creative. So here she is to speak about the title of her talk. Over to you, Karen.
Thank you so much. Well, I'm emotional, so I may as well just honestly, I mean, it's just fantastic to be here. You know, as I said, I grew up in Africa, and it's here, and it's in my blood, and it's just an absolute pleasure. And I think listening to the stories this morning was amazing. That personal element is just brilliant. And I think each and every one of you has got a story in this room. So I've got a bit of time because my presentation is quite short. So I just wanted to sort of explain my situation. So, I mean, you all know me as a PBPK modeler. I grew up in Zimbabwe. I loved arts and history and languages. My parents couldn't afford to send me to university, and the only way I could get there was if I actually signed up for sciences. And so when I was about 17, they threw me on a bus in Harare, and I ended up in Pietermaritzburg for the first time ever. And, you know, and I did sciences, and I absolutely loved it. I mean, it was brilliant. And then I got a job in a laboratory with Professor Drievis, who was an organic chemistry professor, and saved enough money to get me an airfare to London. And I had £100 in my pocket, and I didn't know what I was going to do. And so I went and I got a job in a hotel for a year, just cleaning rooms, doing whatever. I sent my CV around everywhere, and everyone ignored it, and it was horrible. But eventually, Professor Tucker, who is a drug metabolism expert in Sheffield, was kind enough to offer me a position and a PhD. But of course, I hadn't done drug metabolism. My first degree was physics. And, you know, and even though I'd done organic chemistry, you know, I still didn't really know what to do. And the funny thing was, they all thought loved it because, you know, I was fixing everyone's equipment because as part of my physics training, I'd done, you know, I'd done electronics. And so I understood how everything worked, you know, but I mean, in terms of drug metabolism, you know, but, you know, and then of course they then I did a postdoc in childhood, you know, leukemia. And then I ended up having a lectureship in clinical pharmacology and therapeutics. So I'd got this breadth of knowledge, but still didn't really know what I was going to do with it. And this comes back to some of the discussions from this morning. You know, sometimes you're just in the right place at the right time, and it could be that 5-minute conversation that you have with somebody that changes your life and changes your future. And that's why, you know, networking is so important. I'm terrible. Sometimes I come to these things and I go and sit in a corner because, you know, but honestly, make the most of these opportunities because it can really make a difference. And then, of course, they set up SimSip, and I joined. And I know you're recording this, and I shouldn't say this, but I've been stuck there ever since. But that's a joke, you know. I actually really enjoy what I do. And especially when I get to do these kind of things. So without further ado, what I'm going to talk about now is yesterday I focused on lactation and a more general PBPK talk in an African setting. And what I want to do today is talk about pregnancy, also lactation as well. But, you know, we all know it's a big problem, you know, postpartum or perinatal depression. And, you know, and certainly in the Western world, I mean, you know, it's very much a focus of using SSRIs and venlafaxine and more modern type antidepressants. And that's what I'm going to focus on, but I'm going to bring it back to an African context. And so, you know, this is something that I always say to, you know, mentoring at SimSip is, you know, it's not the models that are important. It's what we're going to do with that information. And this is really important. And I always start with, what is the question that you're trying to answer? And in this particular case, you know, what I'm interested in knowing is what is the change in exposure, you know, of antidepressants during pregnancy according to CYP2D6 phenotype. Now, most of us know that the CYP2D6 expression, it increases, it changes during pregnancy across the 3 trimester, and almost by about 1.82-fold. That's a significant difference. But what do we know about how that's affected according to CYP2D6 phenotype? And this is another, so I prepared this presentation for ESDPP, and I gave the presentation in front of clinical practitioners, healthcare practitioners, and pharmacists. And the point I wanted to make, and in fact, there was a debate that they held there, was how much data are enough? And what they were talking about was clinical data. Because, you know, if you think about it, you know, if we want to prescribe venlafaxine or we want to prescribe another antidepressant, there's always this, we can't prescribe it because we don't have enough evidence in the population. That's not good enough. We have enough information for many drugs, and if we know the pharmacokinetics of the drugs or the key characteristics of the drugs, we can extrapolate and we can bridge using modeling. So say, for example, antidepressants, there are exposure data for these antidepressants across the 3 trimesters and therapeutic drug monitoring data in 290 pregnant women, but there were no CYP2D6 phenotype data. We've got metoprolol, also a CYP2D6 substrate, and there were, IV oral was performed, single dose during pregnancy and postpartum, full kinetic data available. Granted, 5 subjects, but it's good data. Again, no CYP2D6 phenotype. We've got metoprolol data, steady state data during pregnancy and postpartum, where they recorded the phenotype. I'm saying here EMs and IMs, but they did actually have PMs and UMs. How can we actually bridge this data and utilize it to make more informed decisions going forward? So lots of numbers here. The important thing is what I'm trying to show you here is this is the robust data set that they captured for metoprolol in pregnant. So basically they collected pharmacokinetic data during pregnancy and after delivery. Now, the big thing about metoprolol is obviously it's got a very high contribution of CYP2D6 to its metabolism. And the bioavailability, it was actually during pregnancy was 0.21. So you're losing about 80% of that drug during first pass metabolism. And then you've got the subsequent metabolism by CYP2D6. And so you can see here that when you're looking at the IV clearance, you've got a 2-fold difference, between pregnancy and postpartum. But when you're looking at the oral formulation, then essentially you're looking at a 6-fold change. So, what exactly is happening here? And I think the thing that we have to always remember is look at the characteristics of the drug. What is important here for metoprolol is that you've got the FM CYP2D6, but you've also got the bioavailability. And that bioavailability is really important because it's putting you on that exponential curve. You've got your 2-fold change for IV, but then because of the bioavailability impact, suddenly you're getting this huge increase. So it is very important. So this is the metoprolol data. So what I did was say, right, we've got a metoprolol model, and this goes back to the point I was making yesterday. Whether we're talking about POP-PK, whether we're talking about PBPK, we have many models available for these drugs. And what we're showing here is the simulated versus the observed data after delivery and during pregnancy. And you can see there there's a significant amount of variability just alone from these 5 subjects. But I only used this model for metoprolol because it had been extensively validated or verified previously for DDIs, but also in EM and PM subjects. And again, this comes back to my point yesterday about understanding these models and about when we shouldn't use them. So that's the metoprolol clearance. Now, I mentioned to you that we've got the IV oral data, but now we've got the metoprolol clearance according to phenotype and trimester, and that's shown in this graph on the right-hand side. And you can see that on the y-axis, you've got the metoprolol oral clearance, and that increases, as you go from early to late pregnancy. And you can see, so you've got the extensive metabolizers on the top in black, and then you've got the intermediate metabolizers below in white. But you can see again that you get that increase, but again, the change that you're getting is less for the intermediate metabolizers. There's a lot to take on board here, but I've got a nice figure later that will hopefully clarify all of this. So we've got this data now. The next thing we need to do is see whether we can actually capture this data using modeling. I've got all of these numbers here. All I'm trying to show you is that there are a number of different ways of presenting data. These are lots of numbers. All I'm showing is that as we go from the early trimester to late trimester, compare that versus pre-pregnancy or post-pregnancy, for all of the different IMs and UMs, we can actually generate these data using PBPK modeling because we have the CYP2D6 abundance data for these different groups. And then also, as I said, we've got this good model. We also have the changes as we go across the 3 trimesters. But I don't want to focus on these numbers. What I want to focus on is this. Now, it looks very Mickey Mouse-ish, and I apologize for that. But what I'm trying to show you here is the change in clearance per kilogram as we go across the gestational weeks. So if you look at these 4 lines here, on the bottom, the green, we've got the poor metabolizers. And then above that, we've got the intermediate metabolizers and then extensive metabolizers and UMs. And you can see that we've got this increase, as we go across the gestational weeks, but also importantly, if we look at the differences between the PMs and the UMs, we have a 24-fold difference in exposure here, or sorry, in clearance here, when we consider the relative change in PM. And that is because as we've gone across the trimesters, we've got the effect happening for pregnancy, but because we're looking at a UM individual that has a high expression of CYP2D6, that is getting magnified. And because of the bioavailability of the drug being so low, that is why we get this huge increase. So a lot of the times when we're reading these pregnancy papers, we hear about, there's this twofold change or change in exposure across the trimesters. But when we're looking at, and especially many of these antidepressants are metabolized by CYP2D6, we need to be thinking about individualized dosing, because the biggest issue here is not the change according to pregnancy, but a combination of that change, but also the baseline abundance as well in these different populations. So really important. And then, of course, in the UMs, the change across the, the change here is 2.8-fold as we go across the trimesters. So really, this is the money shot here, is that this is the thing that we should be looking at and thinking about as we go along. But obviously, this is for metoprolol. But the point I'm trying to make is many of these drugs have similar bioavailability, similar FM, and therefore we should be able to extrapolate. So this is the data now that, that were actually captured during the therapeutic drug monitoring study. And what I'm showing here is the relative exposure. So you've got pregnancy relative to non-pregnant and across the 3 different trimesters. And this is for the 4 different drugs. The purple is fluvoxamine, and then we've got paroxetine. And then on the top 2, you've got fluoxetine and venlafaxine. Now, I mentioned that the parameters were similar for these 3 drugs, and they are. But what we have to remember, for fluoxetine and venlafaxine, they both have active metabolites. And therefore, during this therapeutic drug monitoring study, they captured both the metabolite and the parent, added them together, and showed that as you go across the 3 trimesters, you don't get a significant change. And therefore, they made the recommendation that you don't have to change the dose across the trimesters for this particular drug pair here. However, for paroxetine and fluvoxamine that don't have the active metabolite, you can see that as you go across the trimesters, you get this significant drop. Now, where do we stand with metoprolol? If I take the metoprolol simulations and add them onto that, then essentially you can see that paroxetine, fluvoxamine, and metoprolol are quite similar in the 2nd and 3rd trimester. So what I'm saying is, I would have been able to predict this, even without having clinical data, just from knowing the pharmacokinetics of the drug. You would have expected this. So why aren't we applying this kind of thinking? Why are we insisting that we need to have clinical data for every single drug? We are hindering, the use of drugs, I was going to say vulnerable, but I'll get slapped down by Catriona, underserved populations, in pregnant women. We should be making better decisions. And also, as I mentioned in the previous slide, we are doing them a disservice. We are fighting to get these drugs into pregnant women. And then when we do, we want to make sure that we give them the right dose as well. Otherwise, what is the point? So we need to be better about doing things. And there is a lot of data out there that we can be using and utilizing better. So this is the SSRIs and venlafaxine. And what I wanted to just show you here is the clinical data and their key findings, where they recommended that they didn't need to make dose adjustments for fluoxetine and venlafaxine, but then recommended dose adjustments for paroxetine and fluvoxamine. But the point that I want to make here, these recommendations were based, but in the absence of CYP2D6 phenotype. So again, we've got all of these data, but what can we do? Well, I'm not saying that PBPK modeling is the savior to all, but there were some independent publications here from Raj Baden's group in Birmingham, where what he's done is he's done all of these simulations using fluvoxamine models that were available in pregnant women, looking at the trimester changes and according to CYP2D6 phenotype as well. And in fact, the dose recommendations that that he made across the trimesters were similar to those that were actually shown in the clinical study. Importantly, and this is a point that I want to make. So they took a venlafaxine model that was available in the literature and have made dose recommendations in here. Now, there's one serious flaw here, and that is that the ODM, the active metabolite, wasn't taken into account. If it had been taken into account, and I know this because I've actually simulated it, then we would know that we don't really need to make dose adjustments because we have this active metabolite. And this goes back to the point that I was making yesterday. We have to be aware of the assumptions being implied, the data that are being used, and when we can apply them. So very important lesson going forward. So that brings me on to my next part of my talk, which is venlafaxine itself. And one of the things that we've been working on is trying to advance, or support clinical data that are available in the lactation area. And again, I'm going to go back to the central question. Is venlafaxine safe for use in nursing mothers and their infants? We've got 3 clinical studies, lactation studies, that have been conducted for venlafaxine. RID, the relative infant dose of less than 10%, has been reported. No CYP2D6 genotyping, and various formulations. But even though we've got these 3 clinical studies, we still don't have informed guidance, about recommending the use of these drugs. And this is the problem. And I think this is where the modeling comes in. Even if you conduct a clinical lactation study, there's no guarantee that they're going to make dosing recommendations on that or advise the use of drugs in breastfeeding women. And therefore, I think whether we like it or not, we are going to end up having to use modeling to support this. And if you look at venlafaxine metabolism, it's mainly metabolized by CYP2D6 to the ODV metabolite. That metabolite then undergoes renal excretion, 3A4 and UGTs. Now, this is important because when we're looking at the neonates, we have to think about the metabolism in the mother, but importantly, what is happening when that infant is drinking its mother's milk, it's getting a dose of that drug, and then how is the infant actually handling this? And we have to be able to capture this. So we're talking about neonates here and up to 6 months, a couple of years. So this is typically the workflow. I'm not going to spend a lot of time on this, except to say that we always make sure that the models are working well, and also verify the models in adults, the mothers, and then the children before we get to the neonates. So we're utilizing whatever data are available for us to be able to actually make sure that the model is robust enough to be able to use. And then what we're doing is utilizing ontogenies that we have that have been tested across a number of model substrates before we then go on and simulate. So this is just showing that venlafaxine on the left, ODV on the right, and showing the relative differences in CYP2D6 EMs and PMs. But importantly, what we're showing on the right is venlafaxine plus ODV. So we're combining these 2 moieties and saying that the levels are similar irrespective of CYP2D6 phenotype, which is important. And that's why in most cases, the FDA have said that you don't have to know the CYP2D6 phenotype before you prescribe venlafaxine. So these are the data. I don't expect you to be able to read them, but the key thing here is that there is an RID of less than 10%. But I think the concern here is that you get exposures in the infant that are very high in some individuals relative to the mother. And I think this is the problem that we have. When these values are seen, there may be concern about making a prescribing recommendation. So what we did was we actually had the PBPK model. We simulated different scenarios according to the time, age, 0 to 1 week at the top and down to 6 to 12 months at the bottom. And what we've done is used ontogenies. We've simulated the worst case scenario, said that this is the maximum dose that we're going to get from the mother. If we have this ontogeny for the breastfed infant, is it going to make a difference? And what we're able to explain is the variability that we're actually seeing in vivo in all of those neonates, and capture those situations where we've got high levels of parent drug and metabolite. So, you know, what I'm trying to say here is we're not talking about replacing clinical studies. What we're talking about is supporting and complementing them to provide more guidance and information and, you know, to help make more informed decisions. And for me, you know, I was really, really happy to see that a lot of the work that we've been doing is now actually recorded in the drugs and lactation database. And actually, they're indicating that PBPK models have been used to predict these exposures. And, you know, and this is why I think it's important. I know Colin's going to pop his head up just now, it's time, but that's why it's important, you know, that we have this dialogue to explain, I think, to prescribers what PBPK model, what they can do, and also to explain the fact that we're not trying to replace anything, and we're just trying to support the information that's out there. And with that, I'd like to thank you very much for your attention, and these are the acknowledgements that I make now.
So I was expecting Yoda to pop up and tell us how we're doing for time.
I was watching the clock.
But Karen, as always, you've got an amazing gift in making something that's really quite complex, very, very simple and very, very understandable. And I think that's really amazing when you're informing policy, because it's very clear what you're doing and why it matters. Have we got any questions in the room?
Actually, sorry, the one comment that I wanted to make, and I forgot to add, was the point that you made, I think, in an email when I said I was going to present on this. You said that, are you using amitriptyline?
So this is an interesting one,
Yeah.
yeah, because we've got a protocol that I need to write, funding to do a study on antidepressants out here. And there's two big problems we have. One is that depression doesn't tend to get diagnosed until it's like psychotically bad. And then we're using a lot of like IM haloperidol and things. But amitriptyline seems to be one of the main drugs used. Just that whole thing I said at the start, we're often reliant on older, perhaps more toxic, perhaps less effective medication. But we are starting to see them used more, the SSRIs. And so I think actually it's probably quite timely to do some work on that here.
Yeah. The point I was trying to make is that even though I focus very much on, you know, CYP2D6 drugs with similar characteristics here, this can be extrapolated in African population. If we know what the prevalences are of the CYP2D6 phenotypes or genotypes, you know, then we know what proportion of the women we're actually talking about who may be under-treated if they're UMs and over-treated if they're PMs. And also, you know, with that drug, there are models available. And so we can actually run those simulations and try and come up with the dose recommendations. But of course, there's an active metabolite as well. So that's something else to take into account.
Wonderful. KOD.
Thanks, Karen. So two things. I just want you to maybe comment a little bit about how we can also use some of these results that we get from PBPK modeling with, you know, maybe decent amount of information to support possible study design, you know, because even when we don't, know, a lot, it's still useful for us in terms of, starting from nothing and can inform how we actually conduct a study. That's number one. Number two is also when we try to validate, some of these studies, as we had yesterday, some of our, especially clinical colleagues, they will insist on validation. And some of the, things that we've been using and we've tried to tap into, in the UK, for instance, with one or two studies that I've been involved in, is to use women that have decided not to breastfeed. So we had looking into, especially when the drug is also going to be used in that population, perhaps that's something that we can also, maybe, because I know it's difficult to recruit for, studies like that, when they are also going to, and it's not recommended for use in them. So I just wanted you to maybe comment on that as well.
Yeah, I think this is where PBPK is underused. It's, I mean, this is the area that I'm talking about, is that, it's funny for me when I look at the PBPK models, and I was looking at the posters, first thing I home in on is mechanism. I can't help it. I sort of think, well, why are we getting that change? And I start thinking about that mechanistically. And I think that's the thing about PBPK. I'm saying there's a place for both. I think we should be using PBPK at an earlier stage, but to inform and help with this study design. As you said, we're not looking for a perfect result at that point, but we're looking for more informed decision than we have at that time. And I think the other thing to say as well is that we're fixated on having data available for that drug. We've all done pharmacokinetics. We know that the data transferable. If you've got a drug with an FMCIP of whatever, and you do a DDI study with quinidine, we know what result you're going to get, don't we? If the bioavailability and everything, and why aren't we applying the same logic to these situations here? I understand that we're looking at, vulnerable populations, and there's always that concern, I think, with clinicians and regulators. But we've got to move things forward. There are a lot of data out there that we can use better. Yeah.
So we have one from the virtual audience, and in order to save us time, Vaishni will provide the question, and if we could go for as short an answer as possible. Vaishni?
Sure.
Yes, Karen.
Hi, Karen. It was a great presentation. Maybe one comment just to attach from my end is that you brought up a really important point, and that is, PBPK should be sold as something that's going to support the clinicians and not replace clinical data. And I think for everyone who's trying to get the buy-in of clinicians or clinical people on the ground, it's an important point to take note of. But then on the question, so Venkatesh actually commends you on a great talk. And the question is, do you think we are in a position to model at a granular level? So using CYP2D6 activity score as opposed to PMs, IMs, EMs, and UMs?
Yes, I think we are at that stage. Yeah, there's been a lot of work actually translating across using the activity scores across using PBPK models. Yeah.
Great, thanks.
Was that brief enough?
Absolutely.
I also have a better question, but also just to start, is to say good presentation. But my question is based on just right here.
Sorry.
Back, yeah.
I was trying to sneak away.
Our question was based on looking at the distribution of the CYP2D6, and more especially in the African population as well. We do have a lot of polymorphism regarding the CYP2D6. And now on the implementation, on the models that you have, wanted to ask on the availability first of the models, and also the validation processes that you have, because if we are to implement it, more especially for African population, the correlation between our population group and the models on where they were basically developed might differ. So if we were to validate it first and all of that, so just wanted to check on those processes you have.
Yeah, so we have a lot of really good genetic data, CYP2D6 data from South Africa. That we've utilized in, for anti-TB drugs and things like that. So what I'm saying is a lot of verification has been done. I think, to me, one of the most important points is the prevalence. I understand what you're saying about the distribution, but the more data that we can get, the better. And in terms of actually refining the EM, UM, IM status, or their activity score, or whichever score system we're using, I think the more data we have, the much more confidence we'll have in the results. And this goes back to the point I made yesterday. And in terms of the demography as well, the more specific information we feed into the models, the better the predictions. But we have done some verification. Yeah, and I'd be happy to follow up on that with you afterwards.
Great. Well, thank you very much, Karen. That was amazing, and I'm sure you'll be getting lots of emails. I'm about to hand over to my co-chair, Ochuko, but just as I do so, I just want to spotlight the fact that these beautiful videos that we've been seeing during the gaps and the interludes, these are the handiwork of Ochuko, who has, I think there are actually many people in this room that have skills in the arts as well as the sciences. She has also produced, directed, she has a film on YouTube, which you can talk to her about. And I think many of us have these talents that we don't always think about bringing into the sort of scientific domain. But actually, as we do more communication and engagement, the question is, why not? But I'll hand over to Ochuko.
Now I've been put on the spotlight, right? Thank you, Catriona. So yes, the next speaker, it's been a journey to this final presentation. And the next speaker is really the best person to take this final presentation. He's been working back to back for this conference. You might not know that he's the chairman of the all planning committee. That's Innocent Asimwe. And I hope I got the pronunciation right. And I think it deserves a round of applause for this. It's been a journey back-to-back meetings. Yeah, and here we are at the final presentation with Innocent. He's a pharmacist, and of course, I know that a number of us know a lot more about him, so I'll just hand over to him. Innocent, take it over.
Oh, okay. Thank you. I'm Innocent Asimwe. I'm happy to be here, and it's always tricky to present after a very good presenter like Karen, but I'll do my best. And today I'll be talking about model-based meta-analysis and how you can use it to strengthen evidence-based decision-making. So I'll talk about our work, which we did during 2024. That's part of the Applied Pharmacometrics Training Program, APT. We have current APT fellows, and there are very many alumni here. So this is to encourage you that what you do is very, very publishable. And so Noor spoke earlier at the start of the session. We worked with her. Samia is in the room. You all know Colin. And then Raymond, Eunice, and Venkatesh were our sponsors from Eli Lilly. And so what did we want to add? So for context, let me just leave this. For context, antibody drug conjugates, which we looked at a promising class of targeted cancer therapies. That's because they have an antibody which is linked to a payload or a cytotoxic drug. So because it's an antibody, it targets specific antigens, say on cancer cells. And because it's targeted therapy, it means that you require probably less of the drug, and you are able to increase effectiveness as well as minimize side effects. So in this study, we had two questions. Could we use model-based meta-analysis and the clinical utility index to assess the benefit-risk profiles of ADCs? And so ultimately, what we want to do is to assess benefit-risk profiles, because whatever drug you give will have both benefit and adverse effects. And why model-based meta-analysis? So if you look at regulatory guidance, like for FDA, it's it's recommended that throughout a drug's life cycle, you continuously perform benefit, because we know that, for instance, during phase 3 clinical trials, you are looking at thousands of patients, but some safety signals can't be detected in such a population. Now, when you market it, you're going to give it to millions, and you're able to detect some signals which you wouldn't have detected earlier. Now, once you've marketed a drug, right, you need to assess benefit risk profile. What evidence do you need to consider? So other guidance says that consider all the evidence. Even if you're in phase 4, look at earlier phases, phase 1, phase 2. If there's a different drug in the market, your competitors, look at their evidence and get all that information, and don't make a decision based on just one set of evidence. And that's where model-based meta-analysis comes in, because it's able to utilize all available evidence, whether it's at patient level data. So in red, this is proprietary data. So you have your own data, which is private. Then it can be real world data at patient level. It can be summary level data that can be published data. It can also be published real world data. So whatever data type you have, you're able to pull it using model-based meta-analysis. So it's typically supported by a systematic review, because you need to make sure that you identify all relevant evidence before you can move on. And why is it important for this conference? So as I'll show in the next slides, we didn't conduct a study of our own, because this red proprietary data, you don't really need it. If you have it, you include it, but if you don't, you can use only published data. And because you don't need to conduct studies of your own, it means that even in Africa, if you don't have the resources, you're able to go to the literature, identify the studies which are relevant to you, and then answer some questions which are important. We also looked at the clinical utility index. Okay. And why a clinical utility index? So you typically, if you are conducting a study, you can have pharmacodynamic endpoints or pharmacokinetic endpoints. And for pharmacodynamic endpoints, so pharmacodynamic, how a drug affects the body. You can have efficacy and safety. So if you have several endpoints, if you look at each in isolation, you can reach different conclusions. Now, what a clinical utility index does, it consolidates all those multiple endpoints into one optimal choice and facilitates decision-making. Now, back to what we did, we started with developing a population PK model, and we used model-based meta-analysis. We used the model to perform simulations, then exposure response, and then a clinical utility index. All this is on GitHub, those who are interested in the details. And so step one, again, population PK model, using model-based meta-analysis. So once you have your population PK model, it means now you can use it, once you dose, you give say 0.3 milligrams per kilogram, you can use it to simulate exposure, like area under curve or the maximum concentration or minimum concentration. Now, once you have your exposure, then you can use it. Remember, also had separate exposure response models. Then you can use the exposure response model to determine the probability of achieving a given efficacy endpoint or safety endpoint. For our case, we had objective response rate as the efficacy endpoint and dose limiting toxicity as the safety endpoint. We had two endpoints, so we combined them into one using a clinical utility index. So we did this for one dose, say the starting dose, 0.3 milligrams per kilogram. This example is for trastuzumab emtansine, TDM1. So once you have a clinical utility index associated with the one dose, you move on to the next dose, do the same thing, and then compare and see whether there is an improvement. And then see if there's an improvement from one dose to another. So the question here is, does the percentage clinical utility improvement meet or exceed the CU clinical utility index threshold? So you need to have a threshold, because what if the improvement is 0.1%? Is it clinically relevant? What if it's 1%? Is it clinically relevant? For our case, we tested 2.5% to 20% improvement. And of course, this was an arbitrary choice. It's the clinicians or patients who will see it and then decide on what the most optimal clinical utility index threshold is for a particular disease and drug. So assuming it doesn't pass the threshold, then you select the lower dose. If it does, you go on to the next dose. If it's the highest dose tested, you stop there. Otherwise, you go to the next dose and repeat the process. Now, remember the first step was develop a population PK model. And now we're back to that. And so this is how, for those who are not, this is our population PK model. These are some of the parameters of population PK model. In our case, we looked at clearance, central volume of distribution. So this was a one compartment model. I know some people here are not pharmacometricians, but we'll learn slowly. And so these are what we obtain using model-based meta-analysis. We compare them to previously reported estimates which used individual level data, and they looked similar. So once you have your population PK model, usually you want to see if you can use it to accurately simulate the observed data. And that's what a visual predictive check does. In our case, if you look at the blue, so the dots are the observed data points. The blue lines, this is the median. And then the dashed black lines, these are the percentiles. This is the median, this is the 95 and 50 percentiles. Then the dashed black lines, those are the simulated percentiles, both the 50th or median, then the 5th and 95th. And then the shaded regions are the prediction intervals. So what you want is, you want this blue line, the blue lines to be within the what? The intervals or the shaded regions. And except for a few points, they are the low at these very low observations, so concentrations, we took this forward because these fits were acceptable to us. So we have a population PK model. We've checked that it can be used to accurately to predict the observed data. So then we used it to simulate. So to simulate concentrations, and then we calculated what we call exposure, like area under curve, the maximum concentration and minimum concentrations. So again, the blue lines and the dots are the predicted values plus the 95% confidence intervals. And then the red and green dots are the observed data. So if you look at Cmax was the most accurately accurately estimated, because area under curve we tried, but if you look at trastuzumab deruxtecan or TDXD, these points are outside the prediction intervals. For Cmax, the intervals are quite wide because we had very little data. So once we have a population PK model, we've tested that it can be used to accurately predict exposure. So accurate simulate concentrations, and then we need to link that now to exposure. Now, to obtain the exposure response models, again, we went to the literature and then looked at studies which had published both exposure and response. So by exposure, we'll mean, for instance, the different PK pharmacokinetic metrics. I've talked about maximum concentration, area under curve, and minimum concentration. And out of 55 analysis units, so analysis units, we did that based on cancer type and dosing arm. So if a study has, for instance, 2 different cancer types, evaluates 2 different doses, those will be 4 analysis units. So for TDM1, trastuzumab emtansine, we had 55 analysis units, and the blue, this is the PK exposure. Cmax was the most reported in 43.6% of the analysis units. For the exposure, for the response, we had both efficacy. So efficacy, we had 3 objective response rate, overall survival, and progression-free survival. While for safety, we had 1, the composite endpoint, dose limiting toxicity. Why we chose it, that's a long story, but it's detailed in the publication. So this dose limiting toxicity was well reported, close to 95% of the analysis units. Then objective response rate was the most reported out of the efficacy endpoints. Then these 2 panels show the reporting pattern, and then panel A shows the frequency, number of times PK metrics were reported with exposure response. For instance, Cmax and dose limiting toxicity were reported 24 times. And if you come to this middle panel, you can see that the first, if you look at the first, okay. It's quite tiny. So if you look at this first, so Cmax and then DLT, this and this is, so there are 7 units here. Then this and this, so and so on. So they are highlighted where you see 7 plus 4 plus 3. You see that Cmax is reported with dose limiting toxicity, and it gives you 24, which is consistent with what is in panel A, 24. And the same applies to all the patterns. In panel E, we see that breast cancer was reported 49 times, so 49 out of the 55 units, which is consistent with the fact that TDM1 is approved for breast cancer. And then panel F shows the doses for which the PK metrics were reported. So when they were testing TDM1, they tested 0.3 to 4.8 milligrams. For Cmax and area under curve to infinity, they reported for all the doses. Same for objective response rate and then dose limiting toxicity. Now, for C-mean, overall survival and progression-free survival, it was reported for only the approved dose, 3.6 milligrams. This is important on the next slide because if you want to perform exposure response, you need to have a wide data range. So remember, we talked about the clinical utility index. Now, if clinical utility index, you have multiple endpoints, you want to combine them into one endpoint. Now, in this slide, this is where we decide to choose which endpoints we are going to combine into one. So first, there are 3 columns corresponding to the different PK metrics, and then 3 rows. So each row represents a different stage of drug development. The first is scenario 1, where we look at only phase 1 trials. Then second, scenario 2, both phases 1 and 2. Then last is all phases. So we keep adding data as we go down each row. So in terms of the PK metrics, remember, Cmax was the most the primary metric because it was the most accurately simulated, so it was chosen. C-mean, if you look at C-mean, it was reported for only 3.6 milligrams, so you see it's a narrow range. In the bottom panel, it looks like there's, but from 1.3 to 1.6 is still a narrow range. So, but nevertheless, AUC and C-mean were also explored. Then for efficacy, so we had one safety endpoint, so we had to choose it. For efficacy, we chose objective response rate. Then overall survival and progression-free survival, because they reported for only one dose, you see that they have, if you look at the purple and bluish curves, they are very what? They have a very narrow range. So you could perform an exposure response, we could model that, but really it won't be very reliable. So we went with objective response rate and efficacy. So as for efficacy and then dose limiting toxicity for safety. So usually, if you have two endpoints, the easiest is to assume 50% weight and average the two profiles. But that's not what usually happens. So what we did, we tested different weights starting from 10 to 90%. And we didn't test 0 and 100% because no drug is 100% safe or efficacious. So the red color is dangerous, the safety, that is dose limiting toxicity, and the bluish is the objective response rate. So if you look at the first column, we have more red than blue. So we are giving more emphasis to safety, or we are giving low objective response weight and high dose limiting toxicity weight. We see that we always select the starting doses. That is because if you always want you don't want to get an adverse effects, then you go for the lower dose. On the other hand, if you put too much emphasis on efficacy, you always select the highest dose. The right balance, which selects the approved dose, is quite narrow. In our case, it was 2 to 4%. And of course, it depends on the range of weights you test. And the other thing we saw here was that as we moved from scenario 1, scenario 2, and scenario 3, so as you go down, you're adding on more studies, we saw that the weights increased, which may indicate that the efficacy safety balance shifted towards more emphasis on efficacy as the drug progressed through the development pipeline. So because we didn't know it, if you have a drug, you have no idea. If you have a drug like this case, you have no idea the weight you, so we tested different weights. But assume you have a molecule which has been approved in the past, like in this case, you have TDM1, then later TDXD is approved. Can you use weights from the previous molecule to predict to predict what dose to give? So if you look at the old trials, we have 81%. So we use this 81, apply this 81% to TDM1. And as you can see here, in scenario 1, so 81% weight for objective response rate, similar to the weights for TDM1, and then dose limiting toxicity. So in all scenarios, the dose which would be selected would be 5.4 milligram per kilogram, which is actually the approved DXD dose for breast cancer. But again, as observed earlier, if you include more trials, you reduce the clinical utility improvement or effect size, so from 8.3% to 3.4%. So this, when we published this, we also shared code for a Shiny app. And there, so you can change the ADC, you can select the scenario, you can select the PK metric you want to show on the graph. You can add multiple outcomes. So here we showed only 3, but the beauty with a clinical utility index, you can add as many as you want. You can even add patient-reported outcomes, you can add cost, you can add competitor information, and so on. You can change the CO threshold. We used user-defined weights, but if you are a statistician, we don't encourage this. You can use principal component analysis. So this is published in the paper record. So to summarize, model-based meta-analysis enables pulling all relevant data, including summary level sources, and usually supported by systematic literature review. It's a practical entry point for us because we don't really need new studies. And the clinical utility index balanced how well the drug works with any serious side effects. And this approach can be applied to other drug types, speeding up development and reducing costs. Thanks for listening. Questions and comments are welcome.
Okay, so if we have questions, can you raise your hand, please?
Thanks, Innocent, for that presentation. I just wanted to comment on the exposure response relationship. For trastuzumab, it appears there is quite flat for some of your PK metrics, which is kind of consistent with monoclonal antibodies, as we know for some of those as well. So, do you think that relationship is for most of those PK metrics? Do you think that was showcase what you really wanted to show with this, or another drug would have been, maybe show this a bit better?
So I think so some of them were flat. So if it's about it might be hard to differentiate. If it's about what? If it's about having a steeper curve, it's possible. For instance, you can use the sigmoid function. So there are several ways you can use to represent the individual curves. So we use the simplest, but you can transform the data to look to give you a steeper response. And even when you combine, we used an additive clinical utility index, which again is simplest. But if you use, for instance, the multiplicative one, you'll also have a steeper So ultimately, so usually you start with a question. So we wanted to look at ADCs. So our aim was not to have a steep or fine. We were looking at ADCs, and like you said, most of the curves will be relatively flat. And that's why probably that's why clinical utility is very important, because you look at multiple endpoints, and hopefully if all of them are going upwards, when you pull them together, probably they give you a stronger picture than if it was just one endpoint, which is going slightly upward, then it might not be more convincing than if you have all 5 endpoints. Even if it's the slope is what? It's not as steep, but if they are all giving you consistent results, then I think it's more believable.
Do you have other questions? Okay, Bill, over to you.
I'm often interested in when model-based meta-analyses also include the exposure metrics. How much more do you think you got from the meta-analysis by using exposure metrics rather than dose?
So for the model-based meta-analysis was used for the population PK model.
Sorry, for the clinical utility index for using exposure rather than dose.
Okay, yeah. So the traditional approach is to use dose versus exposure, and one of the reasons we went for an exposure-based approach is so dose has its limitations, and it's harder to account for patient factors, because I know if I give this population the same dose, we'll all have different exposures based on, we have different genders, different ages, weights. Now, if by using the exposure, it should be more accurate, because we are really interested in what is reaching the blood, not what is given. Now, I give you the same dose, you have different exposures. If I use the exposure, because it's varying, and I think it would be more accurate. I don't know if you get it. Okay, thank you.
Do we have any other question in the room before we go to our online audience? Vashni, is there anyone in your room?
Yeah, so more praises, no questions from this end, but Innocent, the chat is going wild about it's being a great talk and great work. And I think it's important to share a very important point from Venkatesh. So he says the clinical utility index analysis from the APT fellows was highly appreciated at Eli Lilly, and it's now being implemented routinely in the oncology pipeline. So excellent.
Thank you. And I think at this point, we should just give a round of applause to all APT fellows who worked on this project. Thank you. And to Innocent, thank you for this brilliant presentation. We have now come to the end of the third session. And now we're going over to panel session. Catriona, would there be anything you want to say?
Just thank you very much for those wonderful talks. Thank you for all the questions and the discussion. I believe now we may have another short video whilst we rearrange a little bit of furniture. Thank you.
Pharmacometrics Africa has supported me for the last 11 years now. I've attended several international meetings, 2 short courses, and most recently the Applied Pharmacometric Training Program, the APT. The APT program to me was a platform for rigorous scientific exchange and for networking. I managed to learn new concepts in pharmacometric research and build onto my knowledge by doing a project that was not within the usual kind of analysis I do in pharmacometrics, given that it had more statistics in it. The day-to-day scientific exchange within the program increased my understanding of the pharmacometric discipline, interacting with the several other projects that my colleagues were working on within the APT program. In addition to that, this was the perfect platform for networking. I got in touch with several new scientists working on pharmacometrics within the African continent, interacted with several tutors that were subject experts in what they do, but also got mentorship from an industry expert on the subject of pharmacometric. I think it brought to me more insights on how pharmacometric research is done within industry. I think there's opportunity to increase your knowledge and learn more about pharmacometric within the context of industry by joining the APT program. This will be critical in building that mass of people that can increase the use of pharmacometrics, whether in research, regulation, or drug development, eventually on the African continent.
The real game changer for me was the soft skills that we developed that are essential for success, whether you're heading into industry or staying in academia. In my case, Colin is truly a master at building relationships and showing exactly how far you can go with collaboration and connection, and how important those types of skills are in addition to your technical skills. And I think Samir, for me, is the epitome of what genuine mastery looks like in a field, well, in this field specifically. Not just knowing the material per se, but embodying the thinking and the approaches that makes one truly effective, right? I would say pay attention to the way Colin builds bridges between people and watch how Samir approaches problems, and then just observe the, can I say, meta learning that is on the table, that is there for people to experience and achieve. There are really deep insights about what professionalism look like, relationship building, and what true expertise is.